Hi, my name is Colleen Campbell. I'm with the Department of Emergency Medicine at UCSD. And today we're going to talk about the aorta and inferior vena cava, as well as other abdominal vasculature. Mostly today we will concentrate our efforts on the abdominal aorta down to the level of the bifurcation of the common iliac arteries. If we have time at the end of our session, we will also visualize the proximal aorta as it arches in the chest. The aorta anatomy, let's start with where the aorta comes into the abdomen, and that is at the thoracic vertebrae at the 12th level, superior and to the left of the gastroesophageal junction. The aorta is 10 to 20 centimeters in length and a retroperitoneal structure. The psoas muscle and the kidney are posterior and lateral to the aorta. The left lobe of the liver is anterior to the aorta, proximal in the abdomen. This provides a very nice acoustic window from the lateral view to visualize the inferior vena cava and the aorta. When we look at the abdominal aorta, the main branches we will concentrate on today are the first branch, or the celiac trunk, and the second branch, or the superior mesenteric artery. We will follow the aorta all the way down to the bifurcation of the common iliac arteries. A normal aorta diameter in a man is 2.1 centimeters. In women, it's 1.8 centimeters. Greater than 3 centimeters is considered an aneurysm. The aorta is posterior to the transverse colon, the pancreas, and the duodenum. The celiac artery is the first main branch of the aorta in the abdomen. The second branch we will concentrate on is the superior mesenteric artery, which is posterior to the pancreas and the duodenum, crosses just distal to the superior mesenteric artery. The renal arteries come off the aorta just distal to the superior mesenteric artery. The technique we use to find the aorta is first we start with a phased array probe and set our depth at about 22 centimeters. We will apply firm, steady pressure below the xiphoid and rock the probe side to side as needed to displace bowel gas to visualize the aorta. Sometimes having the patient take a deep breath helps us to visualize the aorta. We will fan upwards and slide slowly downwards all the way to the bifurcation of the aorta. This is what it will look like when we scan a patient in the transverse view to visualize the aorta. We maintain the steady pressure on the abdomen as we slide the probe all the way down to about the level of the umbilicus. When we measure the aorta, it is very important to measure from the outer wall to the outer wall, including all plaque in our measurement. Greater than 3 centimeters is considered an aneurysm. 95% of aneurysms are located infrarenal. Sometimes we need to differentiate the aorta using Doppler, and what we will see is a high resistance flow pattern, which is characteristic of the aorta. When we put the Doppler on the aorta, we notice high resistance flow, characterized by large anterograde flow in systole, low flow in diastole, Sometimes we will see retrograde flow in the distal branches of the aorta or the distal portion of the aorta. Most branches, however, we will see a low resistance waveform. To find the aorta, first we must find the spine shadow. We will see the hyperechoic spine followed by a large shadow posteriorly. We will notice the aorta anterior to this and on the left. The inferior vena cava is compressible and usually not completely round. It is to the right of the aorta and also has respiratory variation, which is characteristic. The aorta courses more anteriorly as you go towards the bifurcation, so it is important to adjust your depth to a shallower depth as you move your probe down towards the bifurcation. When we look at the proximal aorta, the first thing we will identify is the spine shadow. Just anterior and to the left, we will notice the thick-walled aorta pulsating. To the right of the aorta, we will notice the inferior vena cava, which may look partially compressed in our view. Anterior to the aorta, we may notice another smaller artery surrounded by hyperechoic mesentery. This is the superior mesenteric artery. To the right and anterior to the superior mesenteric artery, we often see the portal vein as it courses anterior and to the left to meet the splenic vein. At the level of the superior mesenteric artery, we may notice tissue, which is the pancreas. The pancreas is anterior to the superior mesenteric artery. Again, if we take a closer look at our structures, we will see the aorta anterior and to the left of the spine shadow. To the right, we will see the inferior vena cava, and in this clip, we actually see the left renal vein, which courses between the aorta and the superior mesenteric artery. Finally, we notice the thin-walled portal vein to the right and anterior of the superior mesenteric artery, which goes on towards the left to confluence with the splenic vein. To differentiate the aorta from the inferior vena cava, we can use Doppler. The inferior vena cava has a low flow pattern on Doppler. It is quite compressible with the probe, and the way we visualize it, we can identify the aorta in the center at the level of the superior mesenteric artery. We will slowly rotate our marker dot upwards, and then we can again identify the aorta in a long view. The long view of the aorta shows us the celiac artery as the first abdominal branch of the aorta, and the superior mesenteric artery, which branches 1 to 2 centimeters below the celiac artery. Posteriorly, we may see the renal veins and the renal artery. In the distal aorta, the inferior mesenteric artery branches anterior about 2 to 3 centimeters before the bifurcation. Neither the gonadal arteries or the inferior mesenteric artery in the distal aorta are well seen with ultrasound. What we do see is the bifurcation of the aorta around L2 or just above or at the level of the umbilicus. We notice it bifurcating into the common iliac arteries. In men, these are approximately 1.5 centimeters in diameter. In women, the average is 1.2 centimeters in diameter. This is a closer look at the distal aorta, and mainly we will concentrate on following the distal aorta down to the bifurcation of the common iliac arteries. Here is a clip showing this bifurcation in transverse view. First, we see spine shadow most posteriorly. Anterior to the spine shadow, we identify the aorta, which now branches into the common iliac arteries. We can see here the IVC is mostly compressed. This is a long view of the bifurcation, in which it is more difficult to identify the area of bifurcation. Oftentimes, we will just see a small sliver separating the common iliacs. Difficulties with aortic imaging mostly surround bowel gas and excessive air. To combat this, we maintain a steady pressure on the abdomen and probe and rock our probe left to right as needed to displace bowel gas. Sometimes we can confuse a dilated stomach for an abdominal aortic aneurysm. If we are not sure what structure we are looking at, again, we can always use Doppler to differentiate the high resistance flow pattern of the aorta from other structures in the abdomen. We also have the right lateral view as our backup plan to identify the aorta. This clip shows an example of what a dilated stomach would look like. The contents are not completely anechoic as we would expect from an aneurysm or an abdominal aorta. Let's move on to the first branch of the abdominal aorta, the celiac artery. This comes from the aorta about 1 to 2 centimeters below the diaphragm and branches rapidly into the common hepatic artery and splenic artery, which make up the wings of the seagull in the seagull sign. The left gastric artery is another branch of the celiac artery, but is rarely visualized as it courses superiorly immediately. To find the celiac, we must first find the superior mesenteric artery, as it is easily identifiable by the thick white mesentery surrounding it. Once we find the superior mesenteric artery, we slowly fan superiorly until we notice the seagull sign. This is when the celiac artery bifurcates into the hepatic and splenic arteries, and this occurs within 3 centimeters. Very rarely do we see the left gastric coursing superiorly. The splenic artery goes on to supply the spleen, the pancreas, and the left greater curvature of the stomach. The hepatic artery goes on to branch into the common hepatic artery supplying the liver and the gastroduodenal artery. This is an example right there of the seagull sign that we see. If we look at this video clip very closely, we can also see a tiny branch closer to the splenic artery, which is the left gastric artery, barely visible in this clip. A freeze frame of this video clip reveals the seagull sign with its right wing being the common hepatic artery and the left wing being the splenic artery. When we freeze the clip at exactly the right second, we notice the celiac trunk giving off the splenic artery, and a tiny branch of the left gastric artery is visualized. On to the superior mesenteric artery. This branches on the anterior aorta behind the pancreas, about 2 centimeters below the celiac artery. It is surrounded by hyperechoic mesentery anterior to the aorta, and this makes it easily identifiable on ultrasound. Below the superior mesenteric arteries, we can see the renal arteries branch. The superior mesenteric artery supplies the small intestine and the ascending colon and part of the transverse colon. It is located posterior to the pancreas. Its branches include the inferior, anterior, and posterior pancreatic duodenal artery. The renal arteries branch just below the superior mesenteric artery from the aorta. The right goes posterior from the IVC to the right kidney. The right renal artery can be sometimes seen in the long plane posterior to the inferior vena cava. This is an example of the superior mesenteric artery. It can be seen surrounded by the thick white mesentery, and posterior to the superior mesenteric artery, we can identify the left renal vein. If we want to take a snapshot of what's going on at this level of the aorta, we may have a better look at some of the structures. The most posterior thing we will see is the spine shadow, and this is the perfect depth to orient your probe to, so that you just see the spine shadow and we can focus on everything anterior to this shadow. Anterior and to the left, we will see the aorta with its thick walls. To the right of the aorta, we may see a partially compressed inferior vena cava. In this view, we see the inferior vena cava giving off the left renal vein, which courses in between the aorta and the superior mesenteric artery. To the right of the superior mesenteric artery, we see a portion of the portal vein, as it will move anterior to meet up with the splenic confluence. More anterior to the superior mesenteric artery, we see the body of the pancreas. If we would like to visualize the inferior vena cava, let's start by looking at its anatomy. It enters the abdomen around T8 level and immediately branches into the hepatic veins. The inferior vena cava is characteristically thin-walled and easily compressible. We can see the renal veins enter around lumbar 1 level, and the common iliacs join around L5 to form the inferior vena cava. The inferior vena cava enters the right atrium at the posterior inferior portion of the heart. It is retroperitoneal and to the right of the aorta. It runs posterior to the liver in a vertical plane. The portal triad can be identified anteriorly to the inferior vena cava. The portal triad is composed of the portal vein, the hepatic artery, and the common bile duct. This is a clip of the inferior vena cava as it comes from the right atrium. We can see the respiratory variation of the inferior vena cava. We also can notice the hepatic vein is the first branch given off, and we can see anterior to the inferior vena cava, we can see the portal vein with its hyperechoic walls. To get a better look at that, let's see the inferior vena cava. We can see hepatic vein and the liver. So the technique to see this. To see the inferior vena cava, let's also start at about 22 centimeters using the phased array probe. We will start with the subxiphoid view of the heart with the marker dot to the right in the abdominal preset. We will find the heart and turn the marker dot towards the head. We will fan slightly to the right on the patient, and then we will visualize the inferior vena cava coming from the right atrium. Have the patient sniff and notice the inferior vena cava starts to collapse. Notice the respiratory variation in the inferior vena cava. We use this with ultrasound to estimate volume status. If we would like to see the inferior vena cava and the aorta from the lateral view on the right, we will place the marker dot towards the head in the midclavicular line, somewhere between thoracic rib 8 and 10. We will initially set our depth about 22 centimeters. As we fan from posterior to anterior, we will first visualize the kidney, then the aorta. Next, we will see the pleura superior and the diaphragm. We will then identify the inferior vena cava as we fan slightly more anterior and the hepatic veins it gives off. It is easy to notice the difference in thickness of the wall of the aorta versus the inferior vena cava. We can also notice respiratory variation of the inferior vena cava. This is where we will place our probe in the midclavicular line at the lower portion of the rib cage on the right to visualize the inferior vena cava and the aorta from the right lateral view. This is a close-up look at where we place the probe. We do not slide the probe anterior and posterior, but we fan the probe anterior and posterior to visualize the structures. And this is a diagram of what we will see. Superiorly, we will see the lung and the diaphragm. We will see, as we fan from posteriorly, we will see the kidney first, then the aorta. As we fan more anteriorly, we will see the inferior vena cava, giving off the hepatic veins to divide the liver into its anatomic lobes. As we fan even more anterior, oftentimes we can identify the thicker-walled portal veins. This is an example of what the lateral view on the right will look like of the structures. First, we will see the aorta most posteriorly, surrounded by its thick walls. As we scan more anteriorly, we will notice the inferior vena cava giving off the hepatic veins. Superiorly to the inferior vena cava, we will notice the diaphragm. The next view I would like to go over is the aortic arch. We place our marker in the sternal notch. The proximal portion of the aorta is visualized as it leaves the left ventricle. We will not see the root of the aorta well in this view, as that is better visualized in the peristernal long axis view of the heart above the left atrium. We will see the arch well in the sternal notch by placing the marker dot towards the patient's right and aiming the phased array probe into the chest. What we will see first is the aortic arch. We will see it to the right, giving off the brachiocephalic trunk, which goes on to branch into the right subclavian artery and the right common carotid artery. Towards the head on the left, we will notice the left common carotid artery, and lower down we will see the left subclavian artery coming directly off the aortic arch. Deep to the arch, we may visualize the right pulmonary artery. The technique to see this involves using the sternal notch as your acoustic window. We will use a phased array probe and put the preset to a vascular mark. We will aim down into the chest and fan very slowly left to right. This is an example of what we will see in an aortic arch view. On the right-hand side, we will see the brachiocephalic trunk. The first branch on the left will be the left common carotid artery. And just lower to that, we will see the left subclavian artery. Deep to the arch, we may get a glimpse of the right pulmonary artery. To get a better view of what we're seeing, I've labeled all the structures. First, we notice the arch. Then we notice the brachiocephalic artery, the left common carotid artery, and finally the left subclavian artery. Less easy to see is the right pulmonary artery. Pathology of the aorta includes aortic aneurysms. This is still the 13th leading cause of death in the United States and accounts for 50,000 annual deaths in our country. The incidence is 2 to 5% for those over 65 years of age. Risk factors include an age greater than 60, hypertension, smoking, and finally, the biggest risk is having a first-degree relative with an aneurysm causes that person to have a 12 to 19% risk of abdominal aortic aneurysm. 5% of aneurysms are saccular and are a focal outpouching of the aorta. 95% of aneurysms are fusiform in nature. Most aortic aneurysms are completely asymptomatic until they rupture, at which point they have a 90% mortality. Patients may present with abdominal pain or hypotension. Only 25 to 30% of patients with an abdominal aneurysm of 5 centimeters will actually have a pulsatile mass. Surgery is considered necessary if the aneurysm is greater than 5 centimeters or if the aneurysm grows more than 8 millimeters per year. As you can notice with this aneurysm on the lower portion of the screen, there is a large amount of plaque associated with this aneurysm. It is very important to measure outer wall to outer wall in this aneurysm to include the measurement of plaque in your measurement. This is another example of an abdominal aortic aneurysm. We can see here it's much larger than 3 centimeters and is pulsatile. Again, we would want to measure outer wall to outer wall. Aortic dissection is also a large problem with a high mortality. The incidence is highest in the 6th to 7th decade. Risk factors include hypertension, connective tissue disorders, aortic dilation, cocaine use, pregnancy. The mortality is 1% per hour after the onset of symptoms, so a high level of suspicion must be maintained to consider the diagnosis. 96% of aortic dissections involve the arch of the aorta. Sometimes the parasternal long axis view of the heart may provide a useful view for diagnosis, as does the arch view. Oftentimes, they are difficult to visualize, and we must rely on CAT scan. This is an example of an aortic dissection, and what we see here are thin paper-like walls which represent the false lumen and the true lumen of the aorta. Here we see an arch view of a very difficult to visualize dissection, seen as a paper-thin line in the middle of the aortic arch. Finally, I'd like to conclude, a man is as old as his arteries, as quoted by Thomas Sydenham. In this view, we see what looks like a large clot in an enlarged femoral artery. On further look, we noticed that this was dissection and the false lumen took up most of the femoral artery. For further reading into this topic, please go to sonoguide.com or emergencyultrasoundteaching.com. I hope you have enjoyed our journey through the abdominal vasculature.